Title: Special Clinical Scenarios in Connective Tissue Diseases. Introduction. Hello friends, welcome back. Today we will explore special clinical scenarios in connective tissue diseases. These are situations where diagnosis and management become more challenging. We'll cover 4 main areas step by step. 1. CTDs in pregnancy. 2. Pediatric CTDs. 3. Drug-induced lupus. 4. Overlap and undifferentiated CTDs. And as always, I'll give you real examples and explain why each point matters. Let's begin. 1. CTDs in pregnancy. Pregnancy in women with connective tissue diseases is considered high risk. Why? Because maternal disease activity and certain antibodies can affect both mother and fetus. Risks include preeclampsia, miscarriage, fetal growth restriction, neonatal lupus, and congenital heart block. Management approach. Ideally, pregnancy should be planned during disease remission. Regular monitoring with obstetrician plus rheumatologist. Ultrasound and Doppler for fetal growth. Serial fetal echocardiography in mothers with anti-SSA RO or anti-SSB ELA antibodies. Safe drugs in pregnancy. Hydroxychloroquine safe and reduces flares. Azathioprine can be continued if needed. Low-dose steroids safest among immunosuppressants. Aspirin and heparin for patients with antiphospholipid antibodies. Vignette example: a 28-year-old woman with lupus plans pregnancy. She is stable on hydroxychloroquine and low-dose steroids. Her rheumatologist advises continuing these drugs, adds aspirin, and arranges close monitoring. This careful planning prevents complications. 2. Pediatric CTDs. Now let's talk about children. Juvenile dermatomyositis, JDM, presents with proximal muscle weakness and skin rash. Calcinosis cutis is more common in children than adults. Steroids and methotrexate form the mainstay of treatment. Neonatal lupus occurs due to transplacental transfer of maternal anti-SSA RO or NSSB ELA antibodies. Baby may have rash, cytopenia, or most seriously, congenital heart block. The heart block can be permanent and may need pacing. Why important? Because in pediatrics, long-term growth, bone health, and school performance are major concerns while treating with steroids or immunosuppressants. Vignette example: a 10-year-old girl develops heliotrope rash and cannot climb stairs. CK is high, MRI shows myositis. She responds well to steroids and methotrexate. With early treatment, disability is prevented. Drug-induced lupus. Some medications can trigger a lupus-like syndrome. Common culprits: hydralazine, procainamide, isoniazid, minocycline, anti-TNF drugs. Key features: symptoms: arthralgia, fever, rash, serositis. Usually milder than idiopathic lupus. Renal and CNS involvement are rare. Antibody clue: antihistone antibodies are positive in most cases. Why does this matter? Because stopping the offending drug usually leads to remission, unlike idiopathic lupus, which needs lifelong treatment. Vignette example: a man on hydralazine for hypertension develops joint pain and pleuritis. His ANA is positive and antihistone antibodies are detected. Stopping hydralazine resolves his symptoms. 4. Overlap and undifferentiated CTDs. Sometimes patients don't fit neatly into one category. Overlap syndromes, when features of 2 or more CTDs are present, e.g. lupus plus myositis or scleroderma plus RA. MCTD is a well-defined overlap associated with anti-U1-RNP antibodies. Undifferentiated CTD, UCTD. Symptoms suggest a CTD, but not enough criteria for classification. Many patients remain stable as UCTD. Some evolve into defined CTDs over time. Why important? Because clinicians should monitor regularly, provide symptomatic therapy, and treat emerging features early. Vignette example: a woman has Raynaud's, mild arthritis, and positive ANA, but does not meet criteria for lupus or systemic sclerosis. She is labeled UCTD and followed carefully. 2 years later, she develops anti-DES DNA positivity and lupus nephritis, now fulfilling criteria for SLE. Dr. Yogesh gives quick reference of most useful points. Now friends, let's wrap up with a crisp reference guide. Pregnancy and CTDs, plan in remission. Hydroxychloroquine is safe. Use aspirin, heparin if antiphospholipid antibodies. Pediatric CTDs, juvenile dermatomyositis needs early steroids. Neonatal lupus linked to maternal anti-SSA, SSB antibodies. Drug-induced lupus, think of hydralazine, procainamide, isoniazid. Key antibody is antihistone. Overlap UCTD, mixed features need monitoring. Some evolve into definite CTDs later. Closing. So friends, that was our journey through special clinical scenarios in connective tissue diseases. Remember, Pregnancy, children, drug reactions, and overlap syndromes all bring unique challenges, but careful diagnosis and management can make a huge difference. Thank you for listening.